Yeah, my name is Sonja and I'm a physio and a researcher. Bear with me. Yeah, what is on our agenda? Next slide, please. I will do a short introduction, and then we have three wonderful talks from my colleagues, each lasting about 15 minutes. And so, yeah, I think I will introduce the speaker one after another during the or before the talk. So I would like to introduce you into the topic. So next slide, please. There is a ongoing debate about the definition. What is chronic pelvic pain, or how it could be defined? What is the terminology? So it depends a little bit on the guideline or the you're referring to, or also the where you're located, because there are different guidelines in Europe and in North America. I've displayed as an example the guideline as a definition from the European Association of Urology. And as you can see, it is chronic pain is about pain that is perceived in structures related to the pelvis, which means that it does not necessarily have to be really located, or the cause has not been located in the emphasizing that it just doesn't necessarily have to be in the pelvis, but the patient receives it as it is located somewhere there. And the definition also emphasizes that it's associated with psychosocial symptoms. So it is quite a holistic definition. But as I said, it's just one example. Next slide, please. And there's also next slide is kind of a busy slide. Not to guide you through all of these axes. It's just to show you how complicated pelvic pain terminology is, that there are so many axes, and so this is why the reason why you might hear different terms, different definitions during this webinar. So next slide, please. And there's also an ongoing debate about the psychosocial impact for patients of the impact of psychosocial symptoms for patients, and how to integrate these into multimodal treatment. These are only some of the most recent resources. As an example, as I said, there's an ongoing debate for like decades about what is the best approach, or what is the effect of this multimodal treatment. Next slide, please. My colleagues and I, we have wanted to did a systematic about the professional management. So as you can see, we screened we searched over 6 databases, and we screened over 1,600 records. And during the study selection process, we were then finally able to include 5 studies. And so these 5 studies are small studies with they're only including women from 9 to, or the sample size from 9 to 33 women, and they use different approaches of interprofessional management, like medication, physiotherapy, occupational therapy. Next slide, please. And what this is also a busy slide. I don't want to go through all these studies in detail, but these 5 studies, 3 of them are they do not have a control group. They are uncontrolled studies, so it is not possible to have a comparison. And most of the studies, as you can see in the last column, do not report the statistical significance of these results. What we can see is that depression and anxiety symptoms are decreasing, also pain severity, perceived pain severity, perceived pain perception. So there are clues that interprofessional management is helpful. However, there is no consensus about what is the best psychosocial or interprofessional approach. So there's still a long way to go yeah, for our for the research or for the management of these patients. So yeah, this was my introduction. Enjoy the rest of the webinar, and I will hand over to Agnes Wand. Agnes is a physiotherapist specialized in pelvic floor physiotherapy. Currently, she's working as a scientific advisor at Signal, which is an association for intervention.
So, hello everybody, I will start sharing my screen. And yeah, thank you for the invite. And as Susanne said already, I'm a trained pelvic floor physiotherapist and I have many years of experience working with patients. Currently, I'm not working in the practical physiotherapy field anymore, but I'm working at Signal, an NGO in Berlin that is working at the intersection between social services and healthcare for survivors of domestic and sexual violence. But also I'm implementing my knowledge about healthcare experiences in this work field now. And today I will talk about the sexual problems going along with chronic pelvic pain problems. And I will present the results of my master's thesis about the condition of genitopelvic pain penetration disorder. And this diagnostical term is a combination of the former individually classified diagnostic terms vaginismus and dyspareunia. And it is applied already in the DSM and also implemented in the ICD-11. And it was renewed, and dyspareunia and vaginismus were put together diagnostically because it was shown that it is actually not always possible to really differentiate between those two conditions. Yeah, I will start a bit with the current state of scientific knowledge, and because genitopelvic pain penetration disorder is a very long term, I will shorten it with GPPPD following. The etiology of GPPPD is that it is actually something that is more prevalent and somehow connected to patriarchic social contexts, which means social contexts in which the gender gap between men and women is very big. It is also more common among individuals who have survived sexualized violence, and it's also associated with anxiety, depression, and attachment issues. The prevalence is quite high. So 16.2% of females aged between 16 and 25 years reported pain with sexual intercourse in a study conducted in Germany in 2020. And it is something very common about this problem that it is more happening among young women. The access to healthcare is not so good internationally, like getting a diagnosis and finding a treatment option is a process of several years in countries like the US, in UK, and in Australia. This is countries where studies are actually available. For Germany and other European countries, there is no studies. So I decided to do an interview studies with people affected by the condition for my master thesis. And I accessed the field via Instagram self-help profiles and a pelvic floor physiotherapy praxis. And I did semi-structured interviews. I took 8 interviews into analysis and did a qualitative content analysis. And for validation, I did a communicative validation. This means that I, at the end of analyzing the results, I showed the result reports and the categories to the interviewees and asked them about their opinion. And they actually agreed and were happy with the results, but they wished for a gender neutral report because for them, like heteronormative pressure and like normative gender roles, what you have to be as a man and what you have to be as a woman in society, caused so much pain for them that they wished that at least in the research about them and their condition and their experiences, They want to be not focused on being females, but being human beings with having this condition. And since gender was such a big thing for the interviewees, I will also now focus my presentation on the heteronormative pressure that was experienced within healthcare by the GPPPD sufferers. And I show some quotes how medical providers actually reinforce heteronormative pressure. So for example, this quote, and then she said, "Don't be like that," and entered her device deep inside of me, is a quote where this interviewed person is talking about one of her first vaginal examinations. And this one turned into a violent experience and made the problem they had to go through even worse. And also the second quote, "Maybe you just need to close your eyes and go for it. Just dig a little deeper a few times." Also shows how this interview person had not been taken seriously with the problem, and how it was even suggested to apply violence to make penetration possible and be able to perform what normal sexuality is. And also this one, and then she said, "If you're uptight like this, you'll never get a man. All the men will run away from you." Also, this quote shows how the interviewed person had been pushed into heteronormative pressure by a gynecologist, and how it was actually how this person was actually accused somehow of being not able to fulfill men's needs with this condition, and therefore it should be very important to overcome it. What also I should add to this, like apart from this like heteronormative pressure that was being applied in healthcare, all the interviewees had really big problems of finding the diagnosis within healthcare. So they could not find a name for their problem when visiting healthcare providers, but all of them had to find the diagnosis, and with that also treatment options themselves. Yes. And in the healthcare system, it was also a big thing that GPPPD is connected with sexualized violence. So on the one hand, it is of course a thing that when GPPPD is obvious in healthcare, we should actually address also sexualized violence to make sure we've excluded this cause somehow. And in this case, in this quote, the person shows that in the gynecology examination, the problem was not being looked at, and the interviewed person had somehow the notion that this was because it was could be connected with sexualized violence, and the medical provider did not want to open this big box, and therefore preferred not to mention at all if something is actually painful or wrong in the vaginal area. But on the other hand, in this quote, well, it actually made me feel even more shattered, thinking all the time that I had somehow been abused and that it would come up at some point and haunt me. This quote is by an interviewee who made the experiences that from healthcare providers, their problem was exclusively being connected to sexualized violence. But then this person had actually no memory of anything like that and started to question the biographical memory, which of course put a lot of stress on them. What the interviewees reported was a very big relief from them, like apart from anything that healthcare could provide them, was that if they could identify the heteronormative pressure they were having because of their condition and not being able to perform normal sex and other things like inserting tampons and all these kind of things. If they could identify this pressure as being there from the outside and being not super necessary, this helped them to really find their own sexuality and to define their own personal being in a sexual way, also without normative society general. So to come to a conclusion, my interview results really show that GPPPD sufferers require gender-sensitive medical support. And what could that mean? So like in the healthcare system, we should question actually the term penetration and then also penetration disorder, because penetration means that something is actively entering a passive structure. And especially as pelvic floor therapists, we know how much actually active the pelvic floor muscles are and how much active the vagina is becoming through the pelvic floor muscle function. And especially the condition of GPPPD shows how this activity is so strong that even it prevents anything from entering the vagina. And we should really question if the term penetration and especially penetration disorder is adequately describing the problem and what is the experience of individuals suffering from this condition. And within the gynecological care, it should be taken into account that vaginal examinations should not be prioritized for every individual coming to the gynecologist. And it should also be acknowledged that there is a need for support and specialized treatments by people who suffer from pain with intercourse. And there should be gender-sensitive communication about GPPPD causes and symptoms, and also the social context. And gender sensitive in this case means like not accusing people who suffered for not being able to fulfill men's needs in sexuality anymore, for not accusing them that they just cramp and they should try to relax better, but to really go a bit deeper and try to find a cause, maybe try to find a relief, but maybe also accept and try to find other ways. And also gender sensitive communication means like how to communicate about sexualized violence. It means that it should be addressed, but in a sensitive and also not accusing way. And yeah, and I think gynecological care and also we as a whole healthcare system, we need to learn more about this still yet. And in the pelvic floor physiotherapy, I mean, we have many tools actually to help people who suffer from these conditions. For example, we can make and create an understanding for female sexuality beyond penetration. We can explain the anatomy of the clitoris. We can explain how sexual arousal on a in a physical way works, and can make understandable that penetration and vaginal insertion is actually not needed at all for sexual pleasure. And we can make the pelvic floor muscle function understandable and controllable. And this can be a big process of physical reconnection and can be an empowerment for people who suffer pain and infunctionality in areas. And this can help people to develop their individual gender role. Yeah, so thank you for the attention. The full results of the interview studies, because this was only a very short view on it, are published here in German, but I think AI can also help with the translation nowadays. And of course, you can contact me here. So also I have sources, and now I will hand over to Alicia Albers.
Very much. I will share my screen as well. So can you see something?
Yeah, perfect.
Thank you.
Yes.
Yeah, thanks for having me. I'm happy to present my master thesis as well as Agnes did. And yeah, I tried to have the theme, the topic of the webinar in mind when creating this presentation. So yeah, I will just give you an insight and introduce myself a little bit. I'm a physiotherapist since 2019. I studied at the University of Applied Science and Arts in Hildesheim, which is close to Hanover. And I finished yeah, my Master of Science in Physiotherapy last year. Right now, I'm working as a specialized physiotherapist, and I yeah, also do research at the third-party founder project right now. Yeah, and as I said before, I'm here to present my master thesis. The title of my master thesis is Experience of Erectile Dysfunction Care in People with Prostate Cancer After Medical Treatment. And I added here that it's a phenomenological perspective, since because of my question, I decided to do to do research on this design. So here I have the structure of my presentation. I would like to tell you about the topic's relevance. Inferring from this, I present the question of my master thesis. I will tell you about the research design and the methods I used. I will give you a little insight in the analysis, and I also translated some quotes. I would like to show you my results, and then, as I said before, I thought about the topic of the webinar, and then, yeah, I thought about a little take-home message for you. And at the end, there will be time to ask questions, have an exchange, or discuss a little bit. First of all, here are some, facts. I found that in Germany, there have been 60,500 cases of prostate cancer in 2018. And it's the second common cancer in men after lung cancer. The prevalence of erectile dysfunction differs from 10 to 95%, depending on the medical treatment. And I think the big range is, in literature, you can find that there's not a number that you can relate on when you're talking about the prevalence. So this is the reason for the big range, since the treatment is so different, could be so different from radiotherapy to chemotherapy and an operation. And the onset of erectile dysfunction differs depending on the medical treatment. I think one really important fact that I found in literature is that sexual needs, psychological and social factors regarding to post-treatment erectile dysfunction are not considered in the treatment after an operation, for example. Was really important for me to develop my question as I did. When it comes to treat people with sexuality, with problems in this field, tabooing, modesty, and stigmatization are relevant. And what is more, I found that there's a lack of qualitative research focusing on men who are experiencing erectile dysfunction post-prostate cancer treatment. So there are a lot of quantitative surveys and quantifying quantifying ED, but nothing that not so much that is focusing on the feelings or anything of men with erectile dysfunction. And what I like to add here is that erectile dysfunction after the medical treatment is a persistent symptom. I think this is really important when we do when we, in comparison to incontinence, for example, men suffer way much longer from erectile dysfunction. For this webinar, I've decided to present the relevance by showing the importance of these 3 different levels with erectile dysfunction after prostate cancer treatment. So what does erectile dysfunction mean on a biomedical level? These are quotes from literature, and on the biomedical level, it just says what erectile dysfunction means when we see the anatomy. Maybe some of you know about this. So it says erectile dysfunction is defined as a persistent inability to achieve and maintain a penile erection sufficient for satisfactory sexual intercourse. So even reading this, I think it's really interesting when it comes to my results. Have it in mind. And on a psychological level, there's a really interesting review from Chambers et al. It says that erectile dysfunction was a source of anxiety, depression, or embarrassment for men, made them question their self-worth, and created feelings of disempowerment and a fear that they may be stigmatized. I think also this quote is really important and shows what this kind of dysfunction has, what effects can also be there when you look on a psychological level. And on a social level, I think this is also, of course, really interesting, that also the social level is affected. It's a really, it's a problem on body function, but also socially, the men feel affected. They say that they could not longer live a normal life, and there's a fear of losing their wife, and it also includes men who define themselves as homosexual, and they avoid to go to parties where there are the possibilities to have sex because of the erectile dysfunction. So on all these levels, erectile dysfunction is a factor for men with after prostate cancer treatment. Yeah, obviously, the findings in literature show that there are some indications of the need to do further research. In addition to the impact prostate cancer treatment has on a biomedical level, there can emerge problems on a social and psychological level no one has thought about before. To identify those factors more precisely and get an insight to the feelings of patients, I developed this question for my master thesis. How do people with prostate cancer experience erectile dysfunction care after medical treatment? Considering my question, I have chosen a phenomenal approach. The phenomenon I wanted to examine is the experience of erectile dysfunction care. Including criteria were prostate cancer diagnosis, medical treatment, such as an operation, and the erectile dysfunction diagnosis afterwards. Unfortunately, finding persons was the toughest part of my master thesis. But luckily, I have found 2 men. While I was recruiting on many different ways, I designed my interview guideline, and here I have a little screenshot of it. It's in German, of course, but it's my main question from the interviews, where I asked the interviewee how did you experience treatment of erectile dysfunction? I plan to do two semi-structured occasional interviews according to Flick et al. As I said, the recruiting process was not easy. My sample consisted of 2 male persons. Both were married and defined their sexuality as heterosexual. On average, the sample's age was 72 years, and the average age at onset of the illness, prostate cancer, was 52 years. The interviews took place in November and December in 2023. And according to I transcribed the interviews with Max QDA. On the right-hand side, I just want to give you a little insight on my codes I did with Max QDA during my analysis. The analyzation is based on Georgi's live word analysis, which I want to show you on the next slide. My analysis based on, as I said, the live word analysis, and it's recommended to use in phenomenological research. The analysis includes 5 steps, and I wanted to break it down like on the right-hand side to understand what I did. My first step was reading the transcripts. Then there's the need to assume a specific attitude as a researcher. I created meaning units from the quotes, and then I had to go a little bit deeper and highlighted psychological meanings. And then I did a description of the phenomenon from each interviewee, and then I combined them. And this is what I want to show you now, my results. But before, I want to give you a little insight in the quotes. I translated them, so I hope you can understand them. I think they show quite well what the interview were thinking about. Really interesting for me was the first interview started the interview by telling me he masturbated in the first night he was at home after the surgery. I think this is really interesting, and there he recognized it's not working. And the other interviewee said that he was so lucky to have his wife and being in an exchange with her. And this is something the other interview also said, that his wife was a really helpful person in this time of his life. And the other thing that's really interesting, I think, that will be shown in my results as well, the one interviewee said that even though the erectile function is not as it was before, things like sexual desire are not gone as well. So this is something I think is really important when thinking about treating erectile dysfunction. Here are my results. There can be seen as the description of the phenomenon experiencing erectile dysfunction care. First of all, I think it's really important that everyone included in the treatment knows that sexuality is an important topic for men with the diagnosis prostate cancer. Nevertheless, dysfunction has not to be associated with dissatisfaction. Even though the changes in sexual life, like removal from penetrative sex, they also make the point that sexual desire and the ability to climax are more important than the erectile function. man emphasizes the social and psychological effects, like fear of losing their wife and the effects of feeling less masculine. Considering the life world of every individual patient, the experience of erectile dysfunction and its care distinguishes, of course. And nevertheless, my interview said that existing care devices, medication, and the exchange with people like the wives or other people concerned, is helpful. So, as I said before, I would like to share my thoughts about the topic of the webinar and the results of my little research I did. I think a holistic view on prostate cancer is inevitable. It is very important to look on the life world from every patient, which includes psychological and social factors. Even though cancer is considered to be life-shortening, the treatment side effects need to be seen and treated as well. For men with erectile dysfunction, it's when you look on the body function, it's good to have in mind that there are sexual function which includes sexual desire, and the possibility to climax is more important than the erectile function. On a psychological level, I think the impact should not be underestimated. For example, the effects on a relationship and masculinity. And I would like to conclude with the possibilities of physiotherapy in men with incontinence or erectile dysfunction. I think pelvic floor exercises which are instructed by specialized physiotherapists who are including devices could help reduce symptoms or even get rid of them. Yeah, thank you a lot for listening, and now there is time to exchange.
Hi, good morning.
Yes, good morning.
Thanks for the beautiful talks. I just wondered if the last two talks highlight the importance of realizing there are other aspects to human interaction rather than the societal demand of, the sexual act, I suppose, that's perpetuated in all its different forms. And when you don't have the sexual act or are unable to do it, then you have to look at all the other things which are probably lacking in society. So I just wondered how the speakers approach that, because we often find that in some of more patients with pelvic floor problems, they lose their husband or they're worried about something because of the sexual act, and they forget about everything else that's probably lacking in society as a whole. Thanks.
Yeah, I would agree to this to a certain level, but also I would say that we should also, as a society, maybe question what are we defining as a sexual act and what not, because also in Alicia's talk, this was mentioned that sexuality is actually a broad thing, and also those interviewed men, they could experience sexuality even though they didn't have an erection. And also in my talk, this was a big thing. So yeah, sexuality is a form of very intimate communication, but can have very broad implications.
Yes.
Yeah, now can you hear me?
Yes, we can. Yes,
Right.
thank you.
So thank you first for the opportunity to join this webinar. I think I will go for a bit speed. So my name is Sonja Soeder. I'm a research assistant at the Charité Endometriosis Center, and I'm working since 2005. I'm belonging to the Pelvic Floor Center with my own practice. So, and my subject today is the invisible burden and interdisciplinary approach to chronic pelvic pain in dysmenorrhea. And okay.
Yes, perfect.
Excuse me about that. So 91% of all menstruating population occurs to pelvic pain or health issue, but nobody was looking for it. And 21% have very hard pelvic pain, so they can't go for work, they're not able to join friends or going to the theater or movies. And yeah, some of them are just lying in bed, collapsed by the menstrual pain and the pelvic pain, who is coming with a menstrual pain. So what we did is an innovation fund project called MEMAF, or period. And it's a very first time that a multimodal team was looking for it. So the menstrual health and the hybrid model for young females from 16 to 24 years. And another aim is to relieve the menstrual pain and identify and treat girls and young women with a high risk of endometriosis and an early stage of their patient journey through a new hybrid integrative and interdisciplinary care model. So we supported by 3 national insurances, and it was this innovation project. And on the period app, you can see here you have functions of data collection, symptoms, pain, painkillers, and evidence-based self-care options. So the multimodal approach between these two things, the period app and the clinical team where I'm belonging to, this is a new part of it. And after I come later back, so it's a gynecologist, a psychologist, a physiotherapy and nutrition who is looking multimodal for the women. So we have 2 phases. So we have the NVF1. For 3 months, they have this risk assessment. And so we have had 3,000 participants who got free resources on hormones, menstruation, pelvic floor health, pain diary. So, and a lot of self-care delivered digitally via the period app. And also a cycle and symptom tracking, what will be evaluated. The stage 2, and that's the most important thing, what we think as clinical as the clinical team. After 3 months, 220 participants are identified as a high risk for endometriosis and were invited for individualized interdisciplinary treatment at the Charité. They could come to Berlin, but the rest was via video consultation over the course of 6 months. Here you have this nice picture about it, and it's a highly prevalent condition, the dysmenorrhea, among young women, and they can significantly impair daily functioning and quality of life. The pain perception in severe dysmenorrhea is shaped by a complex interplay of factors, including high-ended physiological sensitivity, psychological, socio-cultural, and lifestyle elements, like family history and stress. These factors not only amplify the pain intensity, also impact emotional well-being and coping strategies. So what have we done? So the pain perception and the development and a multidisciplinary approach was set by 6 months for individualized sessions. including assessments of each profession. So one session with a gynecologist, one ultrasound session with a specialized gynecologist, 2 sessions with a psychotherapist, 6 of physiotherapy, and 2 of nutrition counseling. The patients reported different level of pain, but also different symptoms to the healthcare practitioners of different specialties at times. So this was accounted for us in therapy sessions, and we discussed it in further appointments. So that was very interesting when we could talk about it and realized, okay, maybe this factor, for example, a depression, that told our psychologist, but not me or to the nutrition, or something like back pain. They didn't tell the doctor because they thought it's only the gynae part of it. So that was very interesting. So we made a list. And one point I didn't tell you yet, important is with chronic pelvic pain or menstruation pain, take the painkillers in time. And here you have a nice overview. With a gynecologist, it was just a number of 8. I show you. You have a pain of 15, but here you can see the first psychological meeting, and after 6 months, 4 months, it depends how much time that took, it's less. And this was without medication, this was with medication. Without medication at the end, less than in the beginning, and afterwards with the right medication, again, better. And this is going through all our appointments. And I think it's something they really need to know. To use painkillers or to use hormones, it doesn't mean you're doing something wrong. You just won't need so much as before, and you're able to join your life again. So most of them, that was the effects I'd like to share with you. So we have already 80 of 220 completed. We have 5 dropouts, but really not a lot. 8 got already surgery because they found a very hard endometriosis or adenomyose, and positive feedback regarding to the online therapy. A lot of people have hurdles, but even the patients who came to Berlin just switched it. So that was very positive. Approximately 30% have a history of depression or, for example, affective disorders or eating disorders. Approximately 60% had positive effects due to the change in diet and hardly any diarrhea or constipation anymore. So it's so easy to do something, you just have to know about it. After talking to the gynecologist, most of the participants know how to use the painkillers, how to handle the pain, and that was very important. Some of them got hormones also, so it was a real clinical treatment. And then number 5, stress was listed as the most common intensifier. So stress was almost pushing the pain and the symptoms. But relaxation exercises and the implementation of a new structure are the best solutions. So most of them taught us at the end, yeah, now I know to handle it. Now I know what I can do. So frequent symptoms were back pain, dyspareunia, jaw discomfort due to the individually tailored selection of exercises. 80% reduction in symptoms was achieved. And most have experienced menstrual pain for 4 to 7 years. And I think that's incredibly long. And were taken seriously for the first time in our study. And approximately 80% were able to resume or intensify their sporting and activities of daily life with an individual exercise program. And a lot of them started to go to the gym or, yeah, continued in a normal range of cycles. So what was our conclusion? Assessing pain in a retrospective manner to different specialists and can lead to conflicting reporting. So additionally, the phase of the cycle can determine pain perception through reportings, as can individuals of the health clinical practitioners performing the initial interview. So understanding the multidimensional nature of pain and dysmenorrhea is essential for developing effective individualized management approaches that address both physical and psychological aspects of this condition. So a hybrid care model as developed in MEMEF, combining app-based integrative self-care and individualized interdisciplinary support may be a feasible strategy to support patients with dysmenorrhea at an early stage of their patient journey. And I think that's very important to see how much we could reach with not a lot of treatments. If I listen to my patients in the practice, they have a long journey to doctors and centers and whoever, or they're just alone. So the multidisciplinary roles can be available adapting prospective therapy plan for patients with dysmenorrhea. And that's important, online or face-to-face. It should be equal handled, because quite often, so I have done all my first introduction to the patient with muscle test, with movement, with how's the position, the behavior and everything. You can handle it very well. We have had almost 1 hour, and all the social situation like injuries, surgeries, accidents, and all other things you can just put in, like all other professions as well. So I think this is important, and our first publication will start in 2026, but at this time, so this results we showed at the World Endometriosis Congress in Sydney, and if you go to some other congresses, then you will see a few more publications like nutrition and everything else. So yeah, we are looking forward to our publications, but the results we could see right now are really wonderful, and it's important that all health clinical providers are working together. Thank you.